Recording. Okay, so today we're going to talk about ARDS. It continues on in chapter 67, starts on page 1620. We talked about respiratory failure, and now we're going to talk about an acute respiratory failure, or ARDS, acute respiratory distress syndrome. So what exactly is it? It's damage or injury to the alveolar capillary membrane. Then your alveoli fill with fluid. It results in severe dyspnea, they will become hypoxic. You'll see decreased lung compliance because of fibrin. You'll get a fibrous buildup. And diffuse pulmonary infiltrates. Normal PaO2 is 80 to 100. We talked about that when we were talking about ABGs, right? In your normal FiO2, which is fractured of inspired oxygen, what are we breathing? Fractured of inspired oxygen, room air, right? What is room air? What percent? 21%, right? Okay. So your PaO2 divided by your FiO2 is your PF ratio. This is not something that you need to know. It's a good to know. And the only reason why I like to talk about it, because it helps you to realize the seriousness of ARDS, or it helps us to kind of figure out how bad it is, in other words. So an example would be, we'll use ourselves. Say our O2 sat is 95%, and we're breathing room air at 21%. So you take 95 divided by 0.21, and that gives you 452. And that is an okay number, right? That is an okay PF ratio. So a PF ratio of greater than 400 is normal. That's you and me walking around breathing air. So say someone with a lung injury, a contusion, or a pneumothorax, or they've been in a car wreck or whatever. Their PF ratio may be around 200 to 300 because you've got some compromise there. Well, with ARDS, their PF is usually less than 200. So that is just to kind of give you an idea of how serious ARDS is. So they're not having an exchange. There's damage to the alveoli, right? We talked about it. Injury or damage to the alveoli. So they are not getting a good exchange.
You say it's usually less than 200.
Uh-huh. With ARDS, it's usually less than 200.
Seem like important to know. If you have the PaO2, why do you need to divide it by 21? Everyone's going to be divided by 21%.
Well, when you put someone on a ventilator,
There won't be 21%.
so this is our, let's go back. So I just want to make sure that when we talk about, I just want to make sure you understand this whole concept. So we got the damage to the alveolar capillary membrane, right? The alveoli fill with fluid. So then we don't have an exchange. So what we can get, we have a lack of O2. So there are some things that can happen. You can get a VQ mismatch like we talked about yesterday, because remember, there can't be an exchange, so you can get a VQ mismatch. you could get an absolute shunt, which means there's no exchange whatsoever, so then the blood is not even getting oxygenated at all. So if you see a blue to red line, it stays blue. If you can visualize what we looked at yesterday. And then you can get alveolar hypoventilation. What does that sound like? Hypoventilation.
You're not breathing in enough.
Right, they're not getting enough. They're hypoventilating. So you'll have increased CO2, decreased O2, and hypercapnic, right? If you have increased CO2, they become hypercapnic, and that can lead to hypoxia because of the acid mixed with the lack of O2.
And this can all happen at the same time.
Yes.
One of these.
It can happen just one of these, or several of these can happen with someone in ARDS.
Okay.
Does that make sense? So you got a lack of O2. And certain disease processes can add to this, right? Because if you think someone who's got COPD, well, their lungs aren't naturally as compliant. So this would mean that they're not going to bounce back as easily. Someone with heart failure, they're going to have an increased risk, right? Because they have decreased cardiac output already. And you need what does the heart have to do with this? The heart has to perfuse you, right? And get the blood to the lungs. So there's several things involved here, and I just want to make sure y'all understand that there's damage and that oxygen can't be exchanged. So before I throw this big pathophysiology map at you, this is right from your book, page 1621. It's a really good pathophysiology map because it shows you conditions that predispose patients to the development of ARDS. And it shows you how you can get an injury to the alveolar capillary membrane, and you might have a damage actually to the cells, right? Because you know everything has cells involved with it. So then you can have decreased surfactant, and what does surfactant do? What is surfactant?
Keeps the alveoli open.
Keeps the alveoli open, right? So if you have decreased surfactant, then what? You're going to have decreased alveolar compliance and atelectasis, just right here for you. What is atelectasis?
Closure and collapse of lungs and lung structures.
Right. And what do you think happens when you have atelectasis?
You actually can't breathe.
You can't breathe, and there's no gas exchange. There's no oxygen carbon dioxide exchange, or very little. So then you get this hyaline membrane formation, which is that fibrous tissue that builds up. And as you can see, impairment of gas exchange, and that leads to ARDS. Over here on the other side, you'll talk about that when you talk about the shock, like sepsis. So what happens is there's a release. This is another concept. This is how another way ARDS can happen. You can get this release of the mediators, the inflammation mediators that cause the alveolar capillaries to leak. And you get pulmonary edema again. So basically your lungs are filling up with fluid and you don't get a gas exchange. So what happens then? Impairment of gas exchange, and that can lead to ARDS. So there's a couple of different ways it can happen. Vascular narrowing. So if you've got someone that already has some of this, say they have vascular narrowing and obstruction, then they're more prone to getting ARDS. Table 67. Does that say 67.6? It just talks about direct and indirect. It's at the bottom of 1620. Direct, of course, would be, what would be direct? I guess you could read the thing, but like aspiration, right? that makes sense, right? A direct injury to the lung. You just took in a bunch of fluid into your lungs. You aspirated. That's a direct injury that can cause ARDS. Sepsis, it's all listed here as far as direct. And then as far as indirect, it's more like toxins and things like that. Sepsis is an indirect effect.
It also has it under common causes of ARDS. Is it both? I don't know why.
Right, because I think
like
because
where sepsis starts in the lungs.
Right.
Okay.
Right. I think, and plus it depends on like what kind of sepsis is it? Is it bacterial, where they like a kidney urosepsis, and due to the fact of infection, gram negative bacteria. So yeah, it just depends. They're still doing a lot of studies and everything on this, because as far as some of these indirect, the exact cause to the alveolar capillary membrane is not always known, other than sepsis when they start leaking. But they're just still doing a lot of research to try to figure out why some people develop ARDS and some people don't. Probably has a lot to do with the inflammation that's already in your body, all that good stuff. Sometimes people with multiple risk factors are 3 to 4 times more likely to develop ARDS. An example of that would be somebody that has acute renal failure, right? And then they develop pneumonia, or they have pneumonia secondary to acute renal failure. So you've got someone in the hospital that has some comorbidities, they got a lot going on. So then they might have a VQ mismatch because of why? Why would they have a VQ mismatch? Pneumonia and acute renal failure.
There's fluid backed up, but they can't do gas exchange.
Right. So they've got this mucus secretions, right, and fluid in their lungs. So they're not having a gas exchange. And then inflammation, right? So, and edema. All of that could cause a combination of things to cause them to develop ARDS. And then you'll talk about how shock can develop into MODS, multiple system organ failure. That would be another thing that happens. It turns into ARDS because of organ failure. And that's pretty serious. And you're going to talk about that when you talk about the shocks. So they divide it, well, here's some stages. So we talked about how fluid, you got a normal pulmonary capillary, and you got your alveolus. Well, you get edema, which is swelling, right? So then you get alveolar edema. And what happens? Those little alveoli start to leak, right? So that fluid comes out. So then you've got more fluid and less gas exchange. So these are just some stages of edema. This right here can lead to diffuse limitation. And diffuse limitation is kind of like the shunt. We were talking about the shunt and the VQ mismatch. Well, diffuse limitation, again, is just lack of gas exchange at all. So you just have unoxygenated blood going from one side of the body to the other because of no gas exchange. So this can lead to that. There's different stages of ARDS. You got your injury or exudative phase. That's 1 to 7 days after insult. You'll see increased capillary permeability. And y'all know what permeability means, right? Just leakage, right? So your alveoli fill with fluid. You get this surfactant dysfunction, right? Less surfactant. So atelectasis can happen. And then you can get your severe VQ mismatch and refractory hypoxemia. Who can tell me what refractory hypoxemia means from yesterday? Right, you're giving them oxygen, but you're not seeing an increase in their SpO2 or their PaO2. So you're giving them oxygen, but they're not improving. Yes. You're going to have increased airway pressure, so it's going to be harder to inflate that stiff lung. So when we talk about ventilating them, because that's the treatment for this, right? So when we put them on a mechanical ventilator, it's going to be harder to give them positive pressure to open up their lungs. So you have to have the higher settings, which can cause more damage. So in green, I have your clinical manifestations written. Increased work of breathing. Everybody knows what that means, increased work of breathing?
Hard to breathe.
Right. It's harder to breathe. We talked about them being in a hypermetabolic state, and they're just having a hard time breathing. So they have increased work of breathing, also due to that stiff lung, right? Decreased tidal volume. So tidal volume is just the amount of air we breathe into our lungs, right? Breathe in, let it out. So they have a decreased tidal volume. Dyspnea, restlessness. And their PaO2 can drop down to less than 60. Who remembers what I said about that? Tattooed. Does everybody have this? So because of that process, it's harder to inflate the stiff lung. So it's harder for us to ventilate them. It's harder when we put them on the mechanical vent. They have the surfactant dysfunction that causes atelectasis. Does everybody have this? I'm going to go to the next one. So another stage is the reparative or proliferative phase. This is 1 to 2 weeks after injury or insult. The inflammatory cells destroy the pulmonary vasculature. And the lung becomes dense and fibrotic. So it's a progressive, right? It's progression. We already talked about it can become a little stiff in the first phase. Well, this phase, things are getting worse, and the lung can become dense and fibrotic. This is the #1 complication because the lungs can't move air. It's almost, it's bad. They don't always come back from this. If it gets to where the lungs can't move air, they're going to be on long-term vent. They could be if they live. And so if the phase persists, if they stay in this phase, the widespread fibrous tissue for the lung, the dense fibrotic lung, becomes irreversible. But if the phase is arrested, which means if it's stopped, They figure out what's going on, treat the underlying cause, treat the patient. They can stop this phase, then the lesions can be resolved. What do you think the heart's doing during all this? Working out really hard, right? Because it's having to increase its cardiac output to perfuse the body, to perfuse the kidneys. You're going to have compensation happening.
So is ARDS one of the things that can lead for pulmonary?
Not necessarily. It's a different... ARDS. So then the fibrotic or the late stage, exactly what it says, 2 to 3 weeks after injury, the lung becomes completely remodeled. Pulmonary fibrosis, you have decreased lung compliance, an even further decreased area for gas exchange, hypoxemia, and these people will definitely require a long-term vent if they survive. This is, if they get to this stage, there's a decreased survival rate. What do you think this patient would look like? What do you think their labs would look like? Let's talk about ABGs again. They're going to be acidotic, right? So let's say, what do you think their pH is going to be? 7.22. Okay, 7.22. What do you think their PaO2 is going to be? 58, 50. Okay. What do you think their SaO2 is? Their oxygen saturation? Less than 80. What do you think their carbon dioxide is? It's high, right? So they're not doing well. There's a 50% mortality rate with this stage. And it's really not known. Like I said, they're still doing a lot of studies. It's really not known why some lungs repair and some lungs and patients recover and others don't. Again, you're looking at probably inflammation that was in your body prior. You're probably looking at comorbidities. But they are, they're still doing a lot of studies on that. The extent, like the initial injury, what happened, to cause this? Was it pneumonia? Was it sepsis? So you're looking at, of course you're looking at the underlying cause, right? Because that's what we're treating. This is a condition of pneumonia. This is a condition of sepsis, right? Let's say you were, they'll often have pulmonary hypertension. I forgot that one. So this is kind of the progression, right? Or the stages. This is what's happening, pathophysiology, what's happening to the patient. And let's talk a little bit about clinical progression. Some people survive the acute phase. The pulmonary edema resolves, and they get complete recovery. Again, the survival rate is decreased for those who enter the fibrotic phase because they're going to require a long-term vent. So it's not always a death sentence, but like I said, it can be. Because some people do survive, the pulmonary edema resolves, and they get complete recovery. As far as clinical manifestations, yes. Of course, dyspnea, increased respirations, increased work of breathing, a cough, restlessness,
What are we talking about right now?
clinical manifestations of ARDS.
Initially?
Yep. All of them. We're going to talk about initial, and then, because early is subtle, right? You may not know your patient is in ARDS in the beginning. You might just say, "Oh, they're so anxious. I've got this anxious patient over here." But they're really having trouble breathing, and that's why they're anxious. They may have clear breath sounds or fine scattered crackles. You're listening through their lungs, and you're like, did I hear something? Yes.
Are they going to be clear, or would they be like diminished?
They'll be clear. And initially, this is early on. Because you've got just those inflammation, you've got some inflammation going on in the beginning. So they can have clear. Because remember I said, you're thinking, I'm sure what you're thinking is somebody that's got like pneumonia that turns into ARDS. This can be anybody. This can be someone that aspirated and their lungs sound clear, and then all of a sudden they sounded clear that morning, and then all of a sudden you came back and they sound horrible. And they've got the beginning stages of ARDS, or ARDS could happen pretty quickly from that. So it varies. It can vary as far as how fast it happens, because you're thinking pneumonia or something like that. ABGs. Or let's talk about like a septic patient. You don't always know that they're septic, right? You're like, they have a fever, they have an infection, and that's why they're doing all these sepsis, their protocols and sepsis, what'd you say?
Alerts.
Sepsis alerts. Because it's so serious, it can turn into ARDS. Well, you've got a septic patient, and they have a fever, and their skin's flushed, and their lungs are pretty clear. But like a couple hours later, they've got full-blown ARDS because of what's going on. Remember, capillaries are leaking, and it can happen pretty fast or it can happen slow. So your ABGs are going to show early on mild hypoxemia. What would that be? What would be mild?
PaO2 could be like 75.
Yeah, it could be right under 80, right? So you might see respiratory alkalosis, and what is that doing? What's respiratory alkalosis? What are they doing?
Increase pH.
They're trying to get rid of that CO2, right?
Yeah. Decrease CO2.
So, your PA CO2 may be 60. Your chest x-ray may be within normal limits initially. But then as it progresses, your chest x-ray is going to look horrible. Do you remember what I said about the wedge pressure?
It only measures the heart.
It measures the heart, right? So your wedge pressure does not increase in ARDS because the cause is non-cardiogenic, right? It's not related to the cardiac function.
Later would it increase because the heart's trying to pump out more?
No. I mean, I guess it would depend on the heart, the condition of the heart. Because if you got a heart that's constantly overworking, then eventually it could show an increased wedge pressure, but it's all going to be related to the heart and not the lungs. Okay, does everybody have that? So late manifestations. A lot of times, I said the chest x-ray may be negative because what happens with the chest x-ray? Sometimes it lags, right? It's not always real time. And it may not show the fluid immediately. But as far as late manifestations, you're going to see diffuse infiltrates like this lung. You see all that white? That really shouldn't be there, right? The symptoms worsen, fluid increases, decreased lung compliance, your decreased PFTs, pulmonary function tests. You'll see diffuse crackles, rhonchi. You might see a pleural effusion on a chest x-ray. Increased heart rate. Diaphoresis, cyanosis. Remember when I said respiratory failure late is cyanosis, right? Same thing. Cyanosis is a late sign. If your patient is turning blue, you have missed something somewhere. Or it has happened so quickly. Pallor. What is pallor? They're pale, right? What is decreased mentation?
They were oriented earlier, and now for some reason they can't really remember.
Right. They were oriented earlier. You come back and they're talking. They're not coherent. Decreased mentation. Hallmark sign. Hypoxemia despite your increase in FiO2. Remember I said they're going to be on a ventilator. That's the treatment for it. Well, if you increase their FiO2, say you increase it to 65, and they're still hypoxic or hypoxemia, then this is it's not good for them. Because you're increasing their oxygen, but they're not responding. Their lungs are so fibrotic, or there's fluid in there, they're not exchanging the gas even with your efforts. Your PaO2 and your FiO2 ratio is going to be less than 200 in this case, a late sign. Like I said, that's a good to know. I just wanted you to realize that it's less than 200 usually with ARDS. What kind of ABGs do you think you'd see? What kind of acidosis? You can see metabolic because what's happening? You'll see respiratory acidosis, but you could see metabolic because why? The kidneys are trying to compensate, right? And eventually they'll run out of compensation. They'll run out of that bicarb. So you can see metabolic as well as respiratory acidosis. You're going to see hypoxemia or that refractory hypoxemia where they're not responding.
And that's the hallmark.
Yep, of late. Clinical manifestations of late. What are some complications of treatment? Well, remember I said the treatment is put them on a ventilator, right? Mechanical ventilation, positive pressure ventilation. So complications, and we're going to talk about ventilation, but complications of treatment is ventilator-associated pneumonia, or VAP. Barotrauma, which is just rupture of overdistended alveoli. Stress ulcers, renal failure.
I have to ask, sorry. Is that because, like you said, the kidneys are really trying to compensate?
And plus, what else do you think's happened? Or they might be on a benzodiazepine, or they might be on neuromuscular blockades to make them so they're not fighting. So a sedation vacation is they take them off all of that to see how they're doing. And also, what does it help you do?
Their situation.
Assess their neuro, right? Because if you have them snowed with a ventilator, you can't assess their neuro. You don't know how they're doing. So that's the last resort. You may go into ICU tomorrow, and you may see your patient on Ativan, and you might see them restrained. But those are last resorts. They don't want to do all that. Because why? Because you can't really assess your patient with all like that. Those are the last things. What do you think you could do for someone besides those things? Well, they can hear, right? Hearing's the last thing to go. You can talk to them. You can reassure them. You can tell them what you're doing. So communication. And communicate with the family. Because a lot of times people work in ICU, they think, oh, I don't have to have any patient interaction. I want to work in ICU. Well, you are interacting with that family. If there's a family, that is who that you are having to communicate with them. So the family can help keep them calm. They can talk to them. So that's why it's really important to teach family and all that. So a sedation vacation is taking them off all that stuff, taking them off any sedation so that you can assess them. And see if sometimes they'll also do that as part of the weaning process so they can see if they can breathe a little better. Take some breaths on their own. Peptic ulcer disease prophylaxis. What do y'all think that is? Yes. Because what's happening when they're sitting there on a ventilator? Acid's just increasing in their stomach, right? They're not eating because they can't. They may have a feeding tube or they may have TPN, but acid will increase. So you want a peptic ulcer disease prophylaxis. And then what is a VTE prophylaxis? Venous thromboembolism? Right. So SCDs, Lovenox, and then daily oral care with chlorhexidine. Y'all know our mouth is like the grossest thing, right? So can you imagine someone who has a tube in their mouth, who it's open all the time, so its air increases the bacteria, right? So it is a huge area for bacteria to breed. So that's why mouth care is so important. And they use chlorhexidine now, the chlorhexidine white toothets and things like that, to prevent infection.
Them going around teaching all the nurses about it. A few times they come across like how important it is, and they have this new toothbrush they put on the suction and everything, so that it's easy to do like this. Okay.
So as far as planning and goals, of course, we want to maintain tissue perfusion, right? So when I said yesterday they may be on a pulmonary artery catheter, and they may have an art line. This is so that you can monitor their heart, right? Are they perfusing? You want to maintain fluid balance. You want your PaO2 within normal limits. Yes.
Maintain what?
Fluid balance. Maintain.
First one. CO? Like
Yes. Yes. Cardiac output.
I have decreased mentation right now.
No, I probably shouldn't have wrote it like that. I'll admit when I'm wrong. I probably shouldn't have wrote it like that. Maybe I was in a hurry. So maintain cardiac output, tissue perfusion. Let's see if I can erase that. Look, I'll erase it. And I'll write it in purple. Okay, so maintain cardiac output, tissue perfusion, maintain fluid balance. You want your SaO2 greater than 90%. We talked about that. You want a patent airway. Yes.
So why would they have less cardiac output?
So as far as respiratory therapy, your goal is to give them oxygen to correct the hypoxemia. And your goal is the lowest concentration possible that results in your increased PaO2, right? Greater than 60. That's your goal. Your mechanical ventilation is part of your management, and you want your PEEP at 5 centimeters. So your PEEP is 5. I said 5 centimeters because that's just your normal physiologic PEEP. Now, someone that has ARDS, they may have a 10 centimeter PEEP. So it really depends. It's per patient. It depends on the patient and what they need. So it may be 5, it may be 10. It can go up to 20 as far as the PEEP goes. But your level of PEEP is your hyperinflated alveoli. Inflate your alveoli. And you can't have too much PEEP because that can compress your pulmonary capillary bed, which will, in the end, put pressure on the heart vasculature, right? And it can cause problems with the heart. So PEEP is just the end tidal volume pressure where your alveoli stay open, it puts pressure there to help open up your alveoli so that there can be a gas exchange. It hyperinflates them. This is a weird fact, and I sometimes like weird facts, but a normal alveolus, so think about your lungs, is about 2,500 milliliters of surface for gas exchange. So think of a tennis court. That's how much room you normally have for gas exchange. Well, when you've got a problem, you got fluid in there, you've got fibrous, you got swelling, then you don't have that anymore. You don't have that area for gas exchange. Well, PEEP will forcibly cause those alveoli to open up a little bit more so that there can be a gas exchange. Positioning is another nursing management. So prone, face down, has been shown to help the alveoli open up a little bit more. I know. It's something to do with physics. And the way you're laying, and it's in your book. It's a good to know. But prone position will help facilitate the alveoli to open. A CLRT bed, which is like a rotating and kinetic bed, that's also, because what happens? You don't want fluid drains, right? So what is one of the things I said for any? Did everybody get that? Positioning, prone, CLRT bed, or kinetic bed. These all help facilitate that fluid movement. And then evaluation. So, what was cardiac output tissue perfusion maintained? We're evaluating what we did, right? Did we maintain cardiac output? Was fluid balance maintained? Do they have no abnormal breath sounds? Do they have an effective cough? Can they cough on their own? Are their respirations within normal limits? Do they have decreased anxiety? Because we've been telling them everything we've been doing. Is their PaCO2 and PaO2 within normal limits? Is their albumin and protein within normal limits? Why would that be a thing? Why would the albumin and protein even be worried about? Right. You think albumin and protein, you think of nutrition, you think of edema, right? So we already established yesterday that most of these patients are in a hypermetabolic state. So they're going to need increased nutrition. So albumin and protein is a big lab for these people. So that kind of ends up ARDS. Now we're going to go into, I'm going to give you a break, but we're going to go right into respiratory failure as far as, not respiratory failure, but vents. And we've already talked a little bit about vents in this, but we're going to go right into that.